Good evening, everybody. I'm very happy to be together with you tonight. We are running a new ESSM webinar. This is another one in a series that we have already started with the partnership of IBSA. And so really we are very happy to continue in this 2022, and then we will continue again in 2023 next year again with IBSA. They are very good in giving us possibility to share our messages and our experience together with all of you. So first of all, I have to say and give a big thanks from the bottom of my heart to these two persons here that are really very active and very proactive in organizing these webinars. So Giovanni Corona, that is the president-elect of our society, and Daniar Osmonov, that is the elected chair of the educational committee. Both of them really have done a lot in organizing this today webinar. I'm very happy to let you know that we have just finished yesterday our 2022 school of ESSM, and as you know, the School of Sexual Medicine now is based on two different parts. There is one group that is following the sort of basic School of Sexual Medicine, and there is another group, the 40 people following the advanced course in sexual medicine. And we all stay together in Budapest, and the school has been organized by Francesca Tripodi, Kobe Reisman, and Answer, and they all spend a lot of time and play a lot in order to give the best results. And we are very close to announce in the early of 2023 the dates for the 2023 session of our school. It's also important for me to give you more information about the ESSM certifications. You know that we do this since more than 10 years already, and we do in collaboration with the European Federation of Sexuology and the multidisciplinary committee, Joint Committee of Sexual Medicine. And we give a postgraduate certification in this field of sexual medicine, and basically we have two different certifications. One that is based on the fellow of the European Committee of Sexual Medicine, that is the FEX, and the EFS and ESSM certified psychosexuology, that is the ECPS. So those certifications will be the date of these will.
I think we have just lost the connection with our president. So until he connects once again, yes, let me just finish describing this. We were just informing about the next examination, and which will be held next year in April. Okay, here he is. So Carlo, you can just go on.
I have a problem of connection. I apologize. I think that you already said that the date is the 22nd of April 2023, and the application will be open for late-breaking submission just in the beginning of January 2023 on our website. Another important information that I would like to share with you is with regard to our Academy of Genital Surgery. And you know that we have started in this year this new project, educational project, and we are now finishing the last step, the last level, level 3, and we are working with our fellows in our surgery, in our theater, and 3D models. And I think that is very good because we have really started this project, and next year again we will do it in 2023. And all the information about this will be announced again in January of next year. Another important thing is about publication. You know that we have our Bible, the Manual of Sexual Medicine, and we are now working on the update edition that will be available next year in 2023. So this is very important because together with the syllabus on clinical sexology and the textbook of surgery, I think that really they represent our important piece of information, and so please everybody's interested, they can join and they can take it under request. Next, please. Last slides, and then I'm quite pleased to leave the speech to the following speakers. It's just to remind you that our meeting, physical meeting, will come back in Rotterdam in February 16 to 18, 2023. So everybody's interested, everybody want to come, please do not hesitate, just come. And I'm sure that after 2 years that we don't do any physical activity, it will be very good, and the program is amazing. And so do not hesitate and just be there. So I think that it's time for me to leave the speech to Giovanni, and Giovanni, please, that's yours.
Thank you, Carlo. First of all, I'd like to thank all the people who are going to see this fantastic webinar. Again, I completely agree with Carlo regarding the possibility that ESSM is going to produce a fantastic Congress, the first one after 3 years, face-to-face. So it is my pleasure also, obviously, to thank IBSA, who gives us the possibility to go ahead with these webinars during these 3 years, and is going to support also our Congress. And in 2023, again, new webinar will be available with IBSA support. So thanks again to all of you and all the fantastic speakers that for sure you will enjoy tonight.
Thank you very much, Carlo, and thank you very much, Giovanni. From my side, I would like to thank IBSA for the outstanding support of the webinars. And we are going to continue our webinar series next year with at least 4 webinars on different topics, including sexual medicine, psychology, surgery, and non-surgical treatment. I also would like to thank our outstanding speakers today. It was a great honor to invite Mr. Droupy. Droupy is a professor of urology from France, Nîmes, and he's not only an andrologist, he is a robotic surgeon, and robotic surgeons are very intelligent. I'm telling that because I'm a robotic surgeon, this is a joke. And he will update in the main treatment or the main milestone in the andrology, because I think we have 3 milestones. The first was the innovation or invention of penile prosthesis, what was in the 70s, and then we had shots, we had alprostadil or injection therapy, which was in the 90s, and finally we had a revolution of the treatment of erectile dysfunction, is invention of PDE5 inhibitors, and we should have updates in our modern time, because this is the old technique or methods of giving on demand and low dose. But what is next? What is the next level? I'm very excited to hear his talk today. Another speaker is a brilliant surgeon and friend of mine, Javier Romero-Otero from the University Madrid in Spain. He's a high volume and very experienced surgeon, European surgeon. And I'm really excited to hear his talk, because he is talking with the eyes of surgeon to the problem of non-surgical treatment. And I think it's very important for all of us. Last but not least, I would like to invite you once again to our next webinars, which is planned for next year's, and of course, to our annual meeting, which is in February 16 and 18 in Rotterdam. And we will also have our pre-course of the ESSM school, which will be 2 days prior to the meeting. Please inform you through our social media and website, and we will inform you soon about our pre-course. So we will start with our webinar, and the first speaker is Professor Romero-Otero, and he will give us updates on non-surgical treatment of erectile dysfunction. Please, Javier.
Thank you so much. In the meantime, let me just remind everybody.
Okay.
Javier, we cannot see your screen.
I'm doing it.
Okay.
Can you see it? Okay. Right now?
There is like a whiteboard at the moment. There's like a whiteboard. So this is probably not the presentation.
Give me 1 second. I will try it again. Okay. Compartir pantalla. Can you see it right now?
It is
Can you see
starting.
it?
It's coming up. So let's just wait a few seconds. Unfortunately, the sound is not the best.
Can you see the screen right now?
Okay, now it's there. Thank you so much.
Okay.
Thank
Can
you.
you hear me?
We can hear you. Thank
Yes,
you.
sir.
Perfect. So I would like to thank you to our new president, Gio Corona, and to our educational committee director, Daniar Osmonov, and I would like to congratulate both of them because they deserve that positions. And I would like to thank IBSA for giving us the opportunity of sharing these educational corners for us to share sometimes. So now I am going to speak about in conservative non-surgical options, but I am not going to speak about PDE5 inhibitors because my partner is going to do it. So the most important thing is that we know that erectile dysfunction can be in a different range of severe. It can be mild or it can be severe. We have different scenarios and also it is related to some pathologies like BPH, other prostatitis, maybe some bladder pain syndrome, premature ejaculation, and other conditions. So nowadays we have to look for some different possibilities for our patients because all the men we are going to treat are different, and nowadays we have a very different scenario and we can choose between different options. So as we know, we are only seeing one side of the pathology, and behind it we have a very important disease. So depending on the possibilities, we should try to fit the treatment we are giving to the patient as much tailored as possible. If we look at the new guidelines in the American Urological Association, it is important that now for the first step, it is not only PDE5 inhibitors, but also at the same level, they are showing us vacuum devices, intrarectal prostacyclin, intracavernosal injections, and other treatments that can be employed. Even prostheses are nowadays for the American Urological Association an option in the same level as PDE5 inhibitors. And that is important because it's telling us that we have different possibilities and that we could be trying to choose the best selection for us. If we look to the European Urological Association, they are also changing the level of the stars to treat erectile dysfunction, but they have changed it not so much as the American Urological Association, but they are putting together at the same level PDE5 inhibitors, topical vacuum device, and low intensity shockwave treatment. So it is important to think that we have different possibilities and that we only not have the PDE5 inhibitors when we are going to treat our patients. I am going to focus in this last paper that we have recently published in Current Neurology, our group. It is a review of the evidence where we included at the end of our research 175 papers, and we are focusing in this non-systematic review of the literature that we developed this year recently. So I will try to summarize the evidence we have available. Also, we are going to look at the data that we recently, the people from the ESSM, we have published in the International Journal of Important Research, and I would like to summarize. We have to speak about all these topics, so we are going to try to summarize as much as we can, because as we can see, we have many possibilities. The first one is the psychosexual therapies. When we look at the psychosexual therapy, we have 7 papers available, and it is important that the majority of them are offering to the patients that psychosexual therapy will improve erectile dysfunction when we are evaluating it. And if we look at the data, we can see that the majority of the studies are with young people, that some of them, it is not only focused in non-organic erectile dysfunction, that they are also focused in organic erectile dysfunction. The number of patients they are involved, it is not very big, but when we look at the results, we can see that it is having an improvement of around 2 points in the IIEF5 questionnaire. So when we look at the psychosexual therapy, the psychosexual help, it is a good option. It is improving the results when we are measuring it with a validated questionnaire, and we have in that 7 papers an improvement. And the improvement is not only in erectile function, but it is also in depression, in anxiety that the patient can be suffering secondary to erectile dysfunction. If we are moving to hormonal therapy, we can see that we have 6 papers studying the deficit of testosterone. So looking at I would like to focus in one of them, that it is evaluating in a randomized fashion 29 patients giving only testosterone plus tadalafil, or tadalafil alone, or tadalafil plus posteriorly testosterone. And if we look at the data, we see that the best option is when we are giving testosterone replacement therapy with tadalafil following the treatment of testosterone. And that means that we need to replace the testosterone to have a good answer of the treatment when hypogonadism is arising. In all the papers, when hypogonadism is present, we have to treat it with testosterone replacement, and we are seeing that the effect is good enough, and we are restoring the erectile function. I am not going to stop in PDE5 inhibitors because my partner is going to do it, but I am moving now to the topical drugs. Topical drugs, we have 2 papers, the most important ones. They are coming from the group of Martinez Salamanca, and they are trying to evaluate the combination of only the topical alprostadil or alprostadil plus a PDE5 inhibitor. And it shows that when you are using both treatments, the results are much better, and that topical drugs is a good option to improve the IIEF5 score in both groups. So the results are better if we are giving it with a PDE5 inhibitor, but also by itself, as we can see in this paper coming from Palmieri group, the improvement is about 2-3 points in the IIEF5 questionnaire. Another good option and very attractive is stem cells that, as all of us know, now they are being employed in very different scenarios. The stem cells can be coming from embryonic stem cells. They can come from mesenchymal stem cells. They are pluripotent and multipotent, and more new stromal vascular fraction can also be employed. The initial results, they want to be and to show some encouraging results showing us some significant improvement, not only in improving erectile function, but also in regeneration of the penile tissue, and it will be provoking at the end of the day an improvement in the erectile function. So the clinical results seems to be good enough. If we look at the data, we have 10 papers. 4 of them are using bone marrow cells. The others are using mesenchymal stem cells. And the problem of these papers is the heterogeneity of the population they are using. They are putting together very different populations, and they are evaluating in some different ways. So today it is still very soon to give any conclusion about the stem cells, but it seems to be something some very promising. They have also proven that when they are doing a penile assessment with ultrasound and Doppler ultrasound, there is an improvement in the flow, and also when we are looking at the questionnaires. So all these papers are pilot phase 1 studies. Only one was randomized, and we think that it is needed more studies and with a longer follow-up than we have nowadays to have any conclusions about the stem cells, but seeing and seem to be very promising. If we look at the phytotherapy and nutraceuticals, we have 26 papers investigating the effect in erectile dysfunction. The majority of them, 19, look at the endpoint of these many substances, that they are very heterogeneous and they are putting all together in this box. And we don't know exactly very well which one is the mechanisms of effect of these substances, but some of them are trying to show some positive effect. If we look at to some of them, like in this systematic review, they want to add us that they are more natural and safer than drugs, and that they can have an impact, a positive impact, all these different substances in the erectile function. I would like to stop in L-arginine, that we can see in this study the supplementation with L-arginine have proven a very important improvement in the IIEF questionnaire, more than 4 points with statistic significance. So I think it could be a new possibility, but obviously further studies are needed. I also would like to speak about Tribulus terrestris, that it is a plant that is coming from Bulgaria, and the results in a randomized controlled trial, they seem to be really, really good. So I just wanted to add this because maybe it is a possibility. We don't know which one is the mechanisms through which it is working, but it could be a new option, and I would like to add it. So I think we don't have still evidence to add all these substances in our guidelines. I think they do need more studies, but could be a good option. If we look at vitamin D, we have 2 papers. In both of them, vitamin D showed an improvement in the questionnaire when it was measured for the study, and the improvement was really important because we are speaking an improvement about 3-5 points in the IIEF, that it is a very good result for the studies. So now we are moving to the platelet-rich plasma. It is completely new for all of us. What we are doing is that the patient, we are taking the blood of the patient and we are just taking the platelet, and then the platelet, what it is supposed to do is that with that high concentrations, we will find more growth factors, including platelet-derived growth factor, vascular endothelial growth factor, epidermal growth factor, fibroblast growth factor, and insulin-like growth factor. So all these should be provoking and promoting a regeneration in the endothelium of the penis. So at the end of the day, we will having a better and a rehabilitation of the smooth muscle and the endothelium, and even they are speaking about neuronal regeneration. And if we look at the papers we have 6 papers in the last years. All of them are with young patients. The population is not very big, around 50-30 patients. And we have also a very heterogeneous population. Some are diabetic, some are not, some are with metabolic syndrome. And the majority of them are not only doing this injection into the penis, but also given other substances like tadalafil, vardenafil, or other PDE5 inhibitors. So it could be an option. It is showing a good improvement in the erectile function. But again, I think we have few studies, very heterogeneous, with very heterogeneous population, and we should try to do further studies to include it. When we speak about low-intensity extracorporeal shock wave therapy, we all of us know it came from a long time ago when Bardi did the first studies speaking about the possibility of regeneration of the endothelial tissue of the penis, and we have nowadays a huge experience on this. I think 29 papers. It's a very good amount of papers. So we are building up some evidence. That is the reason, because it has been already included in the guidelines, not only of the European, but also the American Urological Association. And I think still we have some heterogeneity between the devices, between the doses, between the patients, but I think we can conclude that the majority of them can have a positive input, improving erectile function in the majority of the studies. So if we look at the data we have, again, the majority of them are young patients because they have more possibility of regeneration of the tissue, and some of them are only with shock wave, with the shock wave, but others are adding some substances, and in the majority of them, we can see an improvement important about between 2 to 5 points in the IEF5 questionnaire when we look at it. So it could be a very good option. We know nowadays that if the patient is young and have the possibility of regeneration, for me, it's an option. What about other molecules that we know that they are already in the market and we could have the possibility of improving the erectile function, like the mirabegron, that as we know it can provoke the relaxation of the vascular smooth muscle of the cellulars, provoking an erection. It could be a possibility, it was a theory, but when we look at the data, we can see that all these substances like mirabegron, aspirin, bupropion, cabergoline, and levothyroxine, none of them have proven to have a real impact in good trials, but we have the theory and the possibility of improving all of this impact in the erectile function. I am almost ending. I would like to speak about new substances to inject into the penis. I am not going to speak about papaverine or prostaglandin, that all we know and we have a huge evidence on that. I would like to speak about toxina botulinicum, that it could be a good option provoking the paralysis of the smooth muscle and provoking relaxation and then having an erection of the penis. We have these 6 papers, again, very heterogeneous, but we already have some papers with good number of patients like this of the group of Giuliano with 123 patients, and it has a very good impact in the erectile function. So probably here we are opening a new window, a new possibility. So I would like to underline this kind of injections in the penis, trying to improve the erectile function. We have other possibilities like hyperbaric cameras or patients under treatment with CPAP, and it seems also to have and could be a possibility. Again, very young population, very small studies, very heterogeneous. But if we look at the data, the literature is offering us in these 6 papers, all of them are showing an improvement in the erectile function. So it could be an option, and some groups are working in this effect of the hyperbaric camera. Also, to finish the gene therapy, we only have one paper. It is speaking about the possibility of the introduction of some genes that can be provoking and promoting smooth muscle dilatation, relaxation. They are working through these potassium channels, and at the end of the day, it will be provoking that we are having more relaxation in the smooth muscle in the penis. So it could be a possibility. For me today, it is not a reality, it's just fiction, but in the next future, we have to be looking at all these new therapies. If we look at the conclusions of the majority of these treatments in the paper we published recently, I think today there is only good enough evidence for shockwave therapy, but the other therapies should be further studied in better studies. So to conclude, the cognitive behavioral therapy it's a very good option. It will be improving not only erectile function, but also reduction of anxiety and depression. Hormone replacement is completely known by everybody, and we know that it works and is essential, the replacement in patients with hypogonadism, not only to have a good answer of other treatments, but also to have a good structure in the penis. Combination therapy with alprostadil and PD-5 inhibitors have shown in some studies a good an improvement of the answer. So for us, is an option. In shockwave therapy, it is a more than established option nowadays. Nutraceuticals, with the evidence we have nowadays, it is still a low quality, but there are some substances that can be promising, and we should be studying further. The intracavernous injections with toxinium botulinicum, it seems to be also a new option. Other substances that we are using for other endpoints like miraviron, aspirin, bupropion, we don't have evidence, and the response is really small. So I think we have a very spread of possibilities nowadays. I think we have a very good future, and I think we should be trying to open our mind and trying to tailor it our treatment to all the patients we are having. Thank you very much for your attention.
Thank you, Javier, for the outstanding presentation. Muchas gracias. So we have an answer from our participant, Dr. Otero. For patients with chronic kidney disease, which cardiovascular morbidity, what is your treatment strategy, especially young men with chronic kidney disease or after renal transplantation, but high creatinine levels, seek for help, and drugs may complicate their renal status? What
Daniel, probably should be better to address all questions at the end in order to...
Yeah, I agree.
So go ahead with Stéphane, and we will address All
Well,
questions at the end.
we have two poll questions. Please.
Yes, we would like to just have some interaction. So I have just launched a poll question. You can find the question on your screen and you can vote. We will allow a couple of seconds. Okay, thank you very much. I see people are actually voting. Just a few seconds more and then I will share the results so that we can have a comment. And here you go. This is the answers that we have received. I don't know if Javier, you want to say something or if Daniar wants to make a comment here.
So 71% of participants answered that psychosexual therapy seems to help not only to treat ED, but also anxiety. So Javier, it's a correct answer?
The correct answer is that psychosexual therapy seems to help not only to treat erectile dysfunction, but also anxiety and depression that is associated with erectile dysfunction. So it should be a good option for the majority of the patients.
Thank you very much. We are very short of time. That is why I want to move to the next presentation from Dr. Droupy. He will give us an update on the new methods of treatment or administration of PDE5 inhibitors. Please.
So thank you. I hope you all hear me. Yes.
Yes, sir.
Yes. Good evening to everyone. Thank you for your invitation to share with you update and perspective in actual PDE5 inhibitor treatment. Next step, please. Next slide, please.
Yeah, it just takes a few seconds to move. Apparently something is not working with this presentation.
No.
Let me try once again. All right.
So you can move. Thank you. Next. Next, please.
It's not moving.
Danny, maybe you can use a non-presentation mode.
Yeah.
Go ahead.
Can you see?
Okay, so PDE5 inhibitors, as you know, are used usually as first-line treatment for erectile dysfunction. And next, please. And so they act breaking down the cGMP and allowing detumescence and inhibition of PDE5 promote the relaxation of smooth muscle and penile erection. Next, please. Next. So you know that previous, sorry. So there is 4 PDE5 inhibitors marketed in Europe: sildenafil, tadalafil, vardenafil, and havanafil, with for each one pharmacokinetics profiles different side effects. And the contraindication is the concomitant use of organic nitrates, nicorandil, and they must be used with caution with hypertensive and antihypertensive drugs and during severe kidney or hepatic dysfunction. The prescription of all PDE5 inhibitors in patients with cardiovascular disease should be based on the recommendation of the third Princeton consensus panel. Next. Next, please. So it doesn't work.
It gets stuck.
So the discuss and suspend is summarized here, and I am sure you know it. So next, what is new in terms of PD5 inhibitors? A new formulation proposed by our sponsor, EBSA Pharma, which is the oral dispersible film of sildenafil. And we tested in more than 100 patients in an observational study. And what we've seen is that in patients with mild erectile dysfunction, 100 of these patients respond according to the Rosen criteria. In patients with moderate, it was 75% of response, and in severe patients, 65% of patients respond to the treatment. In a fourth group of patients, we were a patient who previously been treated with other PD5 inhibitor. As we asked them if by switching their previous PD5 inhibitor to the novel formulation, and asking if they are more satisfied with the oral dispersible film that they were with the previous treatment, more than 80% say they were more satisfied. Next. Next, please. So there's satisfaction with this new formulation. We saw after 2 visits of adjustment of the dose that more than 62% of the patients were satisfied or very satisfied. And at the beginning, they were on 50 milligrams, and at the end of the study, only 30% were on 50 milligrams and 25% on the new 75 milligrams. And 45% with 100 milligrams. Next. Side effects were side effects expected with sildenafil. And what we see is that the majority of patients and physicians were satisfied of the sildenafil oral dispersible formulation, which is discreet, easy to take, and with a new 75 milligrams that could add greater flexibility to the therapy. Next, please. So what to do when PD5 inhibitors fail? Next. We know that the main factors affecting PD5 inhibitors compliance is insufficiency of efficacy, loss of sexual interest, return to normal erections, opposition of the partner, and side effects. And patient difficult to treat are patients with prostate cancer treatment, diabetic patients, and patients with arterial insufficiency. Next. What have been seen in patient non-responders to PD5 inhibitors is that sometimes there is suboptimal prescription conditions identified, such as they didn't try more than one PD5 inhibitor, they didn't try at least 6 doses, they didn't try the maximal dose, and then didn't take dietary precautions, and they didn't wait at least 1 hour before to have a sexual intercourse. Next, please. Next. So in these patients, if you try to undergo therapeutic re-education, you can obtain in 76% of non-responders that they became responders with a mean improvement of 9 points of IAF erectile function score. Next, please. So to evaluate non-responders to PD5 inhibitor, you must check whether the prescription was correctly accompanied by a comprehensive management of the sexual disorder, to reassess if the patient or partner fear about treatment, to verify if the price has any impact, to verify the absence of testosterone deficiency, to assess the impact of a possible cardiophobia in patient or partner, and to check if side effects are not dominant, masking the therapeutic effect. Next. So the good question to ask to your patient is, have you tried PD-5 inhibitor at least 6 times under condition of adequate stimulation? Have you tried the maximum dose? Are you taking any dietary precaution? Did you wait long enough after taking the pill before intercourse? And have you tried at least 2 different PD-5 inhibitors? Next. So in conclusion, on-demand oral treatment with PD-5 inhibitor is recommended in first-line treatment for ED. PD-5 inhibitor, however, are ineffective in 30 to 35% of patients. In these patients, 30 to 50 patients can be saved by therapeutic re-education and sexual counseling. And the others are probably candidates to erection inducers such as alprostadil or vacuum or penile implant. But let's see if there is other strategies. Next. So what can we do? We can handling of PD-5 outside the framework of the marketing authorization. We can make switches between drugs, overdosing, association of PD-5 inhibitors, correction of testosterone deficiency, and some experimental options that we've previously seen and we've seen rapidly. Next, please. In this study, we see that switches are possible in both ways. And in patients with tadalafil, among those who switch, 25% return to tadalafil. In those under sildenafil or vardenafil, and those who switch, less than 10% return to initial treatment. Next. In the study that tests the efficacy of a daily 5 mg tadalafil in patient non-responders to 100 mg sildenafil on demand, reminding that only patients with mild erectile dysfunction were included in the study, we can see that randomizing tadalafil 5 mg daily to and placebo, you can obtain 40% of the patient normalization of the erectile function in these patients that fail to respond to 100 mg of sildenafil. So switch can be interesting in this patient. Next. Next, please. Thank you. Association between PD-5 inhibitors, 5 mg daily tadalafil plus 50 mg sildenafil in this patient can improve erectile function in patients with severe ED, plus 5 points. And if you look at the sexually controlled profile, all were improved by the association versus only 5 mg daily tadalafil. So it could be interesting to add 50 mg of sildenafil. Next, please. And this other study of overdosing, because they compare 5 mg daily, 20 mg on demand versus 5 mg daily plus 15 mg on demand, and seeing that the association of both is significantly higher result, best result for SAB3 and global assessment question and IIF. So it's a good solution to improve the results in this population of diabetic patients. Next. Overdosing, once more, in patient failing with 100 mg of sildenafil to increase to 150 or 200 mg can improve the response rate with increasing side effects, but can improve response rate. Another example here, by increasing the daily dosage of tadalafil to 10 or 20 will increase the improvement of IIF erectile function by 8 points versus 20 mg on demand, and increase the response rate in patients. So the increase beyond the authorized doses makes it possible to increase effectiveness with the limit of side effects, obviously. Next. Association have been tried with other drugs. Here you can see with folic acid in a very small proportion of patients who had MTHFR mutation can improve erectile function. However, association with alpha blocker did not seem to be able to improve erectile function. Next. Association with PDE5 inhibitors, as just shown, Javier, did not show any significant change in many RCTs, but next. According to the last RCT presented, the expert opinion is that we need to use testosterone plus PDE5 inhibitors in patients with testosterone deficiency and in patients between 8 and 12 nanomole to try 3 months attempt of testosterone plus PDE5 inhibitors in these patients. Next. Association of intraurethral prostaglandin plus sildenafil was efficient in this cohort of patients that were unsatisfied with sildenafil 100 milligram and unsatisfied with intraurethral prostaglandin. Both treatments make them happy and erection of good quality. Next. So experimental strategies that Javier proposed to you, I will be quick. François Juliano showed that in some patients we can have a complete to partial response using Botox in non-responders to PDE5 or prostaglandin intracavernosal. There is no big studies, and the recent meta-analysis have shown that even if there is some good result, the study's limitation could allow her to interpret it with caution. A larger RCT, multicenter RCT, is ongoing in France with François Juliano, and probably we soon have a response answers at this option. Next. PDE5 plus PRP. Well, there is just one study with a very weird design, and we need more study, more randomized control trial to give an answer concerning PDE5 and PRP. Next. Concerning the use of low-intensity shockwave therapy that would improve erectile function in patients who respond poorly to PDE5 inhibitors, there is 3 shortcuts of study, not always controlled, that seems to say that it's possible to improve, but it's really short studies. Next, so take-home message is concerning the solution in PDE5 non-responders. Therapeutic re-education is needed. Switch to other PDE5 or oral dispersible form can be a solution. Association of daily plus on-demand is a solution. Overdosing could be a solution according to side effects, and association with testosterone or prostaglandin could be effective. And please go to clinical trials for to test Botox, PRP, and shockwave. Next, if I have some time. Is there any interest to use PDE5 inhibitors as a rehabilitation solution after radical prostatectomy or radiotherapy? Quickly, next. Just to remind you that there were some good RCTs, React, Reinvent, that test the option that tadalafil daily tadalafil on demand versus placebo could be a solution after radical prostatectomy. Next. In this study, 9 months after the treatment, after 9 months of treatment, the proportion of patients reaching the score of 22, which was the expected score in the primary objective, was significantly higher in the tadalafil once daily group than the placebo group. However, after 6 weeks of washout, none of the comparison versus placebo was statistically significant, and so the primary objective of this study was not met, and the primary objective of reinvent study with vardenafil was not met. Another way to think about it is to compare early treatment with, for example, sildenafil just after the catheter removal versus delayed treatment 3 months after the radical prostatectomy, and to verify if 3 months of treatment could be effective to improve erectile function at 12 months. Next. In this study, the early sildenafil 100 mg give better results as sildenafil 100 mg started at 3rd postoperative month in terms of quality of erection at 12 months. So, seems to be an interesting option. Next. Next, please. Considering rehabilitation in patients with radiotherapy, sildenafil have been tested in this MRCT in many patients with a primary objective of improvement of spontaneous erectile function at 24 months. And as you can see, there is no difference at 24 months between placebo and sildenafil. And they conclude in the study that it's needed to treat more than 6 months. Next one. This other study with tadalafil 5 mg daily with the primary objective of erectile function at 30 weeks after 4 to 6 weeks washout did not show any difference in the 2 arms of the study, treated or placebo or treated, and so they conclude that tadalafil is not interesting to prevent post-radiotherapy erectile dysfunction. Next one. So we well know that PDE5 inhibitors is not the only a factor implicated in the erectile function following treatment of prostate cancer. As we can see from the data from the REACT study, in patients with satisfying sexual intercourse before surgery, it's the technical surgery that is important, robotic, with complete and nerve sparing, give a better result. Next. In patients with poorly satisfied sexual intercourse before surgery, age is important, but PDE5 inhibitors rehabilitation can be a factor implicated in the results of erectile function following surgery. So, next, following treatment for localized prostate cancer in motivated patient, verified testosterone, and probably used early daily plus on demand for I think more than 9 months. Plus sexual counseling, plus lifestyle changes, and probably vacuum device. Thank you for your attention.
Thank you, Mr. Droupy, for the great presentation and timing. So we have one question for the pool question. Please, Daniela, can you show us the questions, the multiple choice question?
Yes, so here you have a question. So as I said before, take your time. Just read the question and answers and vote. Okay, let's just give another few seconds so that people can okay. Let's reach another few. Okay, just a few seconds and I will terminate. Okay, and I will show the results. So if you want to make a comment on this.
Mr. Droupy, please comment on it.
Oh yeah, I think that the first one is okay. The second one is okay, and tapsilocin did not show any improvement. Testosterone is okay, and I think everybody has good options. And PRP is not proven for the moment, so good answers for everybody.
So summarizing, I would like to thank our speakers for the outstanding presentation. We had not too much time, but the topic is too big to explore all aspects of the non-surgical treatment. This is our last webinar this year, but next year we will have our webinars, at least 4. And I would like to encourage you to join us face-to-face in Rotterdam in February 2023. Thank you very much and stay tuned.
Bye-bye. Thank you.
Thank you. Thank you very much.
Bye-bye.
Bye-bye.
Thank you.
Thank you, Daniela.